everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. I have two very, very special people with me today. I have Ricki and Hayley. They are related, but I'm going to let them tell you about that. Hayley, you want to start?
Yeah, so I'm Hayley Brown Buxton Punch. Troubleshooting my name again. Got married this year, but I touches director of programs and partnerships, where I pretty much work alongside my mother and do all the things. Kind of, I just want her to be able to show up to things, and I can do the behind the scene things, which is nice. But yeah, we work pretty well together, and I've been an advocate pretty much since she was diagnosed when I was 19. I decided that she was going to pay me for this work moving on. So here we are.
So yeah, you actually before we started where we met at birth, at her birth, and she's probably been my boss for her whole life, but she really is now. And I actually pay her for it. What a concept! But I'm the co-founder and CEO of Touch, the Black Breast Cancer Alliance, and I'm a 12-year survivor of triple negative breast cancer. Hayley was my caregiver while I was sick, and now she's my caregiver now. Ever since then, but we work together, and we're a crazy mother-daughter duo doing this work. This is my God job. I kind of made it her God job, and I don't know what else we would do. So we're here.
Ricki, did I hear you say God job?
Yes.
Can you tell me more about that?
Yeah, so I'll tell you my story real quick. So I had triple negative breast cancer, stage 3A. Triple negative is the worst one. It has the highest mortality rate. Black women get it at 3 times the rate. And when I had it, we didn't have any targeted therapies for it specifically. It's the only breast cancer subtype that does not have a drug to prevent recurrence. It comes back very readily, usually in a year, and kills women. 40% of people who get it, or patients who get it, are under 40. So it's a nasty disease for young women. I was older than that, but I had a double mastectomy. I did 6 rounds of the standard of care chemo then. I did 6 weeks of radiation. I was told, okay, you have no evidence of disease. Come back in 2 months for a scan. I went back, it was almost exactly the day of my first diagnosis, a year later, and they found 5 spots on my chest wall. My doctor said, okay, Ricki, you are now metastatic. I don't have anything else for you. You have 2 years to live. Get your affairs in order. And I said, I can't really die right now. I have a daughter at Dartmouth. Haley was a sophomore. I had to pay tuition. I said, me, you, and some beggars, we got to work this out. Like, what are we going to do about this? And so I went to Dr. Google, and everything was, you're going to die. You're going to die. If you're black, you're really going to die fast. And on the 3rd page of Google, I found the Triple Negative Breast Cancer Foundation. So I called them, my now very good friend, Hayley Dinnerman, and she said, I'm going to find you a doctor. And in Atlanta, where we lived, and she did. She found us Aretha Reagan, who was an amazing oncologist. She was probably one of about 5 docs in the country at the time that were actually researching triple negative breast cancer. So she put me on 2 experimental drugs, which are now standard of care, carboplatin and Gemstar. And I did a bunch more chemo, and I didn't die. And so I know that God left me here to do this work. I made it to her graduation, and we kept on going and started doing advocacy. And I wake up every morning and say, okay, God, what are we doing today?
Oh, okay, I have so many questions for you. Can you maybe tell me about blesties? I think you guys call yourselves blesties.
Yes, we do.
Tell me more about that.
It's a term of endearment. So I used to say breasties all the time, but there's an organization named the Breasties. It's a group of young women who are previvors, and so they kind of claim their word back, and so we made up a new word. And so I always talk about how blessed we are as alive breast cancer survivors and thrivers. So we're blesties. We kind of, actually, Jordan, her husband, made up that name.
Yeah, we were trying to think of what we could
call ourselves.
Because the thing about the breasts is they do use that word a little bit differently. It was actually really funny because we were having a work retreat that ended up being in Miami. So my mom was like, "We're never going back to Miami for a work retreat. You guys did not work," aka me.
This is wake up at 2 in the afternoon to be at the pool.
But while we were doing that, we thought of my husband the word blesties because we were looking for a term that encompassed kind of the again, for us, our work is what's Black about this, right? We focus on Black breast cancer, and so we thought about the word breasties and how do we make this more Black? And it's we all pretty much grew up in some kind of church setting, right. And the concept of feeling blessed and feeling deserving is a large part of our community, and so that word just worked really, really well, and so we went with it. Now we have T-shirts, logos, all kinds
Yeah,
of stuff.
if you look at that, like breast. So,
Okay, I'm gonna ask you probably a dumb question. I apologize. But can you tell me what's black about breast cancer?
all right, so when I got sick and I started to dig around, I'm a marketing person by trade, so I live by PowerPoint, like making PowerPoint decks, right? Showing research, trying to figure out what to do, right? And so I started putting all the data together in a PowerPoint presentation. And when I saw, Black women have a 41% higher mortality rate than white women. Black women have a 39% higher recurrence rate of breast cancer than white women. Black women under 35 get breast cancer at twice the rate, die 3 times the rate of white women. Black women between the ages of 20 and 29 have a 58% higher chance of dying from breast cancer than white women. I can keep going. The stats are horrible. Black women are 3 times more likely to get triple negative breast cancer. And so I put this all together in a PowerPoint presentation. I said, something is wrong. And no one could explain the numbers to me. And I went to the big breast cancer conference in San Antonio that happens every December. And I started talking to the pharma companies that make breast cancer drugs. And when I painted this picture for Black women and said, this is a devastating situation. This is basically a crisis.
Yeah.
And what are you doing about it? No one had really thought about it that way. I said, well, something's wrong. So I'm going to call it Black breast cancer. Black breast cancer is a different disease. And then I went back and looked in history to look at the clinical trials for all of the drugs that are standard of care that we all take. And there were no Black women in the trial. And I said, well, these drugs are not working for us. And then I started to look for scientists doing research. And it started to bubble up. And now we have this community of scientists that are basically validating and proving that a white breast cancer cell looks different from a Black one. And we're doing it by subtype, by stage. And so basically Black women die of breast cancer at any stage, including 0, any age, any subtype.
And any level of affluence, you recently found out too, like having the same insurance as this white counterpart doesn't change their outcomes either.
Yeah, we have a scientist at Emory, and she did a study that found that Black women who have good health insurance still have a 60% higher mortality rate than white women with good health insurance. Black women who live in a high socioeconomic neighborhood have 126% more likely to die of breast cancer than their neighbors in the same neighborhood. So it's not about money. It's not about status. It's about science, and the cells are different. The drugs are not working for us, and we need different science. And that's why we're so focused on advancing the science and trying to get better drugs and trying to get more Black women into clinical trials. Also, right now, Black women only have a 3% participation level in clinical trials, which is basically 0. And frankly, the FDA can't even explain what that number means. Like, how many women is that? And they stopped measuring it. So until we get more Black women into the research of developing the drugs, we're going to keep dying.
And I think too, when you talk to the FDA, because again, we're like, what is it? Let's fix it. We don't even care who the problem, where it started. Let's just fix it.
Yeah.
When you've been doing the research, but talking to them, like now the FDA has made it so clinical trials have to have, a diversity plan, right? But there's not many criteria for that. It's just like have a diversity plan. There's no like this is what that needs to entail,
Yeah,
and so exactly. And so like right now there's this thought of like we told them to have a diversity plan, but like there's no checking on that. There's little accountability about what that actually means. And so I think we just have to like dive into that criteria.
Can I maybe summarize what I'm hearing from you guys? Because I think there's a very, very important point y'all are making that I'm not sure is well understood in the broader breast cancer community. Because what I'm hearing you say is it's not about socioeconomic status, it's not about money, it's not about access, it's not about wealth, it is about the biology of the disease.
Exactly. Now, clearly, access to care, when you get the screening guidelines, all of those things play a role. But at the end of the day, we're dying because the drugs don't work. We're dying because, clearly you could blame it on the fact that since we didn't get screened under 40, because the milligram guidelines are for 40, that we probably got the breast cancer diagnosed at a later stage. That clearly also plays a role here. But still, when you get someone who takes the drug and it's a white woman to a Black woman, the Black woman's going to die.
Wow.
Yeah.
Do you guys know from your work whether there's any sort of genetic studies done on the differences?
There's a bunch of genetic studies. I recently learned about a thing called variants, and actually it's a variant on your cell, and we know that Black women have different variants. So we're actually working with Melissa Davis. She's an incredible researcher at Morehouse School of Medicine. She just got a Cancer Grand Challenge grant, and we're doing the patient advocacy with her. And she's studying 4 factors. Okay, so the social determinants of health. So what's your body mass? Where do you live? What are you eating? All those kinds of things, right? The genetics of your cell. And clearly though, genetic breast cancer is only about 5% of breast cancer. Okay, you have to have a gene, right? But we know it.
Yeah.
And we don't know for Black women because there could be some genes we haven't identified yet. Okay, so in the Black community, a family history is pretty equivalent to having a genetic history. So if you've got a couple generations like we do, I don't have any genetic mutations, but we have generations on one side. So the other one is genomics. So that's like the biology of the cancer cell. Right? And the last thing is epigenetics, which is the environment. So do you live in Flint, Michigan, where the water is bad? And so our study is basically those 4 factors, studying those 4 factors, a Black cell versus a white cell for breast, pancreatic, and prostate. And we're doing it in the UK, Ghana, Nigeria, South Africa, Ethiopia, and Kenya. And she's done research in West Africa already that's validating that there are significant differences. She already identified a gene in Ghana called the Duffy gene that could be attributed to triple negative breast cancer in Black women. So we're looking at those 4 factors, and now we're looking at the gestalt of all of these factors, like how do they impact each other. We put them all together, cancer cells and analyze all those filters together. What does that look like? So there's been genetic research done, there's been some genetic, but not, and even in the genomic research, there are no Black bodies in the cells that we're studying.
And I think too, it's also like so many women, like her college roommate, who's also a blessee, like when she went through her cancer diagnosis, and now she's an amazing survivor, but no one ever asked her if she wanted genetic testing, and so she didn't get genetic testing until years later, despite the fact that like she has a daughter and like kids, and they could have just said, do this for your kids. And so but she has BRCA, and she didn't know until 10 years later. And so it's like, why are we not even making it standard of care to get genetic testing when you get diagnosed, so we can even dive into this research?
So she ended up having her ovaries removed because she had a risk of ovarian cancer, and she has a daughter. So,
oh man. Okay, so I had a question for you, Ricki. How did you go from being a marketer to knowing so much about the biology of the disease?
I studied it. I wanted to figure out why I was sick, and I found some really good doctors to help me. So when I first moved to Maryland, after I was sick, I quit my life and started new, and I moved back home to where I grew up in Annapolis. And I still had my report. I was just a month out from my second go round of chemo. I met my doctor at this Conan luncheon that somebody else too. And so I said, "Can you flush my port?" So when you have a port, you have to get it flushed and you get cleaned up. So often. And so I haven't found anyone to do it. And she's like, "Why do you have a port?" And I said, "Because my oncologist in Atlanta told me I would have to have it for the rest of my life. She said, you can't just when I come back for triple negative. You may have to see the port." And she wouldn't take it out. And Dr. Regina said, "Maybe we'll take it." We had the OR1, and she took it out. But even just the mentality about triple negative was you're going to die, you're going to get it back. So I know I'm crazy, right? So that's how I met my doctor, and she was like, "We're not taking this. We're going to take it out." You
Okay, can I have 2 questions for you.
Okay. Did I answer the last one? I feel
Yes,
like I didn't.
you totally did. You totally answered the last one.
Okay.
One I think is I'm just gonna ask it, and then you can tell me if I should change my question. Okay.
Okay. Yeah.
All right. So one on the port, I hear you. I had a port for 18 months, and
Okay.
I am amazed the doctor told you that you couldn't remove it.
Yeah, I had it for 2.5 years.
That to me is just
Like, what if you still had it?
I know. I had my tissue expanders for for 2.5 years because I had to go back on chemo, so I couldn't get my surgery.
Ricki, that just I feel I don't think I haven't heard any anger from you at all on this system. I am feeling angry right now.
You know
Just
what?
why?
I know so many women that died from what I had. I feel so blessed to be here that I'm not angry because I feel like my experience gave me my purpose. And it is my God's job. I feel like God gave me this job to do. And so I'm not angry. You're so much younger than me though, so you should be angry. I'm angry when I see young people with breast cancer, with triple negative breast cancer. And I'm angry that we don't have the drugs that we need and the resources that we need. And that's what drives me to yell at people every day because I am angry when I talk to them. I'm like, your baby is ugly. What are you doing to help us? Like, what are you doing? And I'll give you a hug. But give me a different baby because this one's not working for us.
Okay, so my like potentially inappropriate question is, I haven't heard you say this even once so far, and I'm definitely probably going to be putting words in your mouth. And I know you're not saying it, but I know one of the things that drives me in the work we do at Manta is the injustice of it.
Yes.
Because there is an element of injustice, right? Which is...
There is. I mean, there is no health equity. People talk, we were just doing this panel with blackdoctor.org, and all these pharma people have the title, I'm the director of health equity. I'm the VP of health. What the hell do you do? Because there is no health equity. What are you doing? What is your job? Tell me how you do this. Show me the money. Show me what you got from me. Because the way I look at it is we don't have health equity. We have a lot of health illiteracy, and Hayley actually hates when I use those words because it blends stuff like a on a patient. But people just don't know. Black people don't talk about health at the kitchen table until Uncle Pookie gets his leg amputated or Grandma Edith is in hospice. We don't talk about it. We don't know about it. We keep a lot of secrets from each other. The secrets are killing us. And we don't know. You don't know what a clinical trial is until you have to do one, or until you're in a crisis, right? So we don't know. And so I don't think we're going to get to health equity with people being not educated to the extent that they need to be and being treated with the golden rule. What your mother taught you when you were 2 years old. Treat others as you want to be treated. And when everybody wakes up in the morning, every doctor, every scientist, whatever, and says, I'm going to treat everybody like I want to be treated. Yeah. And so we send patients back to the doctors so often saying, you go back to that doctor and say, is that the treatment plan you would give your mama, your auntie, your grandma, your daughter? Because if it's not good enough for your family, it's not good enough for me. And that's we educate them. And, I think between Hayley's, education experience and my marketing, we've created these messages that we test and are resonating with patients. And we try to help them deal.
I want to shout out my first week at work. Not really. I was like taking a quick vacation when my school year ended, and then I was going to start working for her. But I met with, I was visiting my friends in California, and I met with a nurse navigator who's a very much a part of our community. Auntie Z, she was like, I'm your aunt when I first met her, and she was like, no, breast cancer is a social justice issue. And when she had framed that for me, it was a really great framing for me to just start this work, because I did have that in the back of my mind and still do. And that's why I feel like you choose words like we are going to be iconic about this, because in order to move this needle and change this issue, we have to see it as the urgency that we approach a social justice issue,
So I really appreciate you framing it that way, because in preparation for this podcast, I assumed we would be talking about social justice. I had not assumed we would be talking about the biology of the disease being different. And I think that's actually the reason I say those two things together is because I think part of the problem I think is in the breast cancer community is when we talk about race, when we talk about socioeconomic status, when we talk about social determinants of health, there is a blasé acceptance of it.
Yes. The social determinants of health, I feel like there's this big bucket that you just throw shit into.
Correct.
Okay, well, obesity, or, you didn't nurse your babies or whatever. And I see that happening, and it's so much bigger than that. It's so much broader than that. And so we try to break it down and say, focus on the science. What is happening with these cells? What is that drug actually doing to these cells? I don't care about what they ate for dinner or that they live in a food desert, or if the cells are not functioning the way that they should, the drugs aren't going to work.
Yeah, the access to care, like, yes, we agree. We need the access to care. With that said, if the medicines don't work, then what's the access to what? Like, we want the medicines to work. And so, like, we, there's, it is a twofold issue in that way, but like, we can't say, hey, like, let's fix the access to care issue if the medicine's not working.
Now, Auntie Z will tell you that, she works at an inner city hospital in Oakland, and she triages her patients before she can even talk about chemo. When was your last meal? Where are you living? Where are your kids? Where are you going to sleep tonight? So she does have those conversations because of who her patients are. And so those are issues. Those are clear issues, but they're issues for any disease, for anything, not just breast cancer, right? She could have diabetes and have the same issues. So, but for breast cancer, even if you give us the medicine, if the medicine isn't right, and frankly, you know what, I believe this is true for many diseases, okay? Because most drugs are tested on 50-year-old white men.
Yes.
So when you see these Black people with diabetes at age 50 getting blind and losing limbs, and the white person taking the same drugs at age 50 thriving, what's wrong with that picture? To me, those drugs were never tested on our bodies, and they're not as effective. We're seeing it with heart disease, with diabetes, with kidney disease, and so I really believe what we're seeing in breast is going to be rampant across every disease state when you start to look at the science. And we just came from this conference where there are, 100 people in the room talking about this, talking about cancer and talking about the black diseases, right? Kidney disease, heart, all the things, cardiovascular disease. But I feel like we came into this space with breast cancer to look at something different. I wanted to understand why is this happening? And I don't feel that the other guys have gotten there yet. But they're going to get there because I believe the same stuff is happening. Those drugs are not made for our bodies. People weren't tested. They weren't tested on Black people, and they're dying in different numbers. So if Black people have a higher mortality rate across a plethora of diseases, something's wrong. And so I feel like, they just haven't gotten there yet. And I've been like, the ass.
And we were talking about breast cancer is a funny world because it's like women led. And so like things just happen faster,
Well, breast cancer, we have more than any other cancer, than any other disease, really, because it's women.
Yeah.
And we're in the right? Like, how can I help you, babe? But,
That's the fun part of the work. Yeah. We don't really see them besides our partners.
Right.
I want to draw a parallel, and maybe potentially an unfair parallel, but so I grew up in India. I came to the US for undergrad. But when I hear you talk about breast cancer, it reminds me of breast cancer back home, right? Again, it's South Asian women are not studied, similar issues, but not enrolled in trials. We are bucketed in Asian, and Asian is, well,
everybody, right?
Southeast Asian,
right?
Genetically, we know we're different,
right?
And I remember this moment where my oncologist and I were having this debate because she wanted me to go on a specific type of hormone therapy. And I was just like, this makes no sense. She's like, it's guidelines. I'm like, yes, but look at the trial. Look at the number of women at 30 who were enrolled in this trial. It was south of 3%. And I was like, okay, now do a demographic cut. And tell me how many 30-year-old South Asian women were in this trial. We're talking 5 people? 2 people? And you're going to tell me you take 10 years of treatment on that? And so we had a whole debate on it. So I eventually, she was like, you should try it, experiment with it, see how you feel. And I was like, okay, fair enough. Like, N of 1 experiment. All right, I'll try it. I came back and I had these like horrible joint pain, like horrible joint pain. The conversation was, Mira, that's not in the trial. We haven't studied that adverse effect. It's not in the trial. I just happened, and this was pure coincidence, I happened to talk to a clinician who happened to be a PI who bought that drug to market. And in conversation with her, I was like, hey, I'm having these symptoms. It's not in the trial data. She goes, yeah, but it's a known thing. It happened in the South Asian population that we had. But because the N was so small, it never made its way to the actual study.
Never did. Yeah.
I just remember that being like,
so typical. It's so typical.
It's like going to like it's whenever you go to the DMV, right? It's like hating that experience because usually someone's looking at a list of things and saying, if you don't have these things, you just can't get, we're not going to service you today. It's like these guidelines, right? And so it's like the fact that somebody just looked at this piece of paper and said, do you check these boxes? Or like, here's the medicine for you because you check these boxes, versus like looking at
Using
you
a
as
brain.
a whole person,
Using a brain.
using their brain. It's like, why am I getting the same experience in my health? You expect it when you go to certain places, but like
Right.
in healthcare, you expect what we want is individualized care. Right? We want it to be an experience where you get what you need based on even like I've heard moments where great oncologists said, I know your daughter's getting married. Let's make sure that your chemo is planned around that so you can be a real person. You know what I mean? Like even those small choices would make a really big difference for people who are in trials, want to be part of the science, but like don't know that that's an option, or like not all oncologists give you that option.
Yeah, well, that's treating you like you want to be treated, But even like a lot of the protocols, like there's a protocol that a double mastectomy is equivalent to a lumpectomy plus radiation, right? So you have to get cut your boobs off. Well, guess where that study was done? In Sweden, 60 women. The BRCA gene came from, I believe it came from where do the Mormon people live?
Oh my goodness.
Utah?
I'm talking about Utah.
Yeah.
Utah. There's no black people in Utah. Thank you.
We'll have a conversation later.
But I mean, a lot of these studies that are driving standard of care did not include women of color.
You can find the one study to back up your work, and it would just be like this small thing, right? Like that's what we're doing.
That's going to drive standard of care. Yeah.
You can just jump off this ledge because you saw one piece of information from this obscure thing or article. And so it is like, how do we make sure that people are doing this homework and have the space to do this homework? Do they have Wi-Fi to do this homework?
I wanted to share. I'm so happy you just said that because I wanted to share. Actually, I'm going to go back to something you said before I go there. I had never heard anyone compare getting cancer treatment to going to the DMV.
I just did that for the first time, and I'm going to do it again because it's like, why is this a thing?
Yeah, I think you are totally right. I think that is actually an incredible
analogy.
Yeah.
That is brilliant. I think that is such a good analogy. I think it is so accurate. I actually agree.
There's a checklist. Let's go down the checklist. And frankly, the checklist isn't thorough. The checklist was developed by somebody who hadn't really thought about it because
it was probably made in Sweden.
Yeah, because the black people get a different checklist because they don't get genetic testing, they don't get genomic testing, and they have a different checklist. Or the people.
Do I need a different checklist because I look this way?
Right.
Is that what I'm saying? Like where is this criteria coming from, and how are we deciding how it's implemented? And then while we implement, are we looking outside of it just because this person is presenting something new, like joint pain, right? Are they like taking a second to say, hey, let me figure out why that is? Not like, oh, sorry, we didn't see that in the study, Or
why did my nails turn black? Or why did my tongue turn black? Or like, we're having different symptoms that were never recorded. But frankly, every black woman who does chemo, any person who does chemo, you are doing a clinical trial in your body.
Yes.
Because that drug was never tested with your body before. So we're all, so when I explain clinical trials to people, I say, you're doing one right now. Because if you're putting this chemo into your body, you hope it's going to react in a way that's been seen before, but maybe not. You don't know. And for me, I took THC, toxin, cytoxin, the cocktail, and it didn't work for me. My cancer came back.
I think you said something super, super important right now. And honestly, it's the reason we call our podcast what we call it. So the podcast is called The Patient from Hell because there's a book that was written by a professor at Stanford that I happened to get my hands on. Actually, someone gifted it to me when I got diagnosed. And he essentially argues that medicine, as it's done today, especially trials, is done on populations. It's cohorts, right? It's groups of people.
Yeah.
And the reality is, if you are an outlier that deviates from the cohort it was tested on, clinicians and medicine generally do not know how to treat because they're not trained that way, right? The science is not done that way and they're not trained that way, which means that if you're a patient that you are an outlier on any dimension, the only way to navigate oncology is to figure out the self-experimentation, because you're totally right. You getting a chemo drug when the trial was not done on someone like you is effectively like you getting that drug with no
Right.
data.
Exactly. It's totally that way. It's totally that you're getting that drug with no data.
That's why I actually love the Manta Cares notebooks. I like to write things out. I wish I had when she was going through her diagnosis, because a way to just like track the symptoms as we see it. That's why we have, we have been working through nurse navigation, in clinical trials through touch care. But like, it's so important to start recording those things, because like, how cool would it be if we find like, oh, the third week of everyone's thing, they go this way, and it's like we can start to like make these things.
Yes.
How great is it when patients say third week, take off because it's going to be rough, because like anything like that would be so great.
Even the guidelines, the current guidelines from the U.S. Task Force are, basically it says if you are at high risk, these guidelines do not work for you to get a mammogram at age 40. What does that mean? Black women, women with BRCA, and women over 70. So there's a if you read the small type, these guidelines, we don't have guidelines for Black women.
Well, it also doesn't say what. There's no link to here's a risk assessment or here's a thing to like actually help you.
We just don't have any guidelines for you because we don't have the data.
Ricki, I'll share. This is your comment right now is so timely. So I had to switch insurances because I was on a PPO plan, switched to a different plan. So I had to switch oncologists, classic like healthcare moment. Anyway, so I used to the point you're making, I'm not Black, but I'm South Asian and I skew young. So on those two dimensions, I'm an outlier from like the standard.
Yeah, from the standards, right.
And I have high dense breasts, which means that a mammogram is not helpful.
Doesn't work for you.
Doesn't work. So my oncologist under my PPO plan was like, you need to do a whole breast ultrasound. So I've had mammograms now for 3.5 years and had whole breast ultrasounds with it. I go to this new system, and this is April 18th. It's been 4.5 months of me negotiating to get a whole breast ultrasound. And I'm walking into the reason I say it's timely, I'm actually walking into an appointment today with a new oncologist. And in anticipation, I sent the guidelines highlighted the part.
Right.
Like, this is why I am not. This is why.
Right.
And I sent that. That was the only once I sent it in writing was when the system took me seriously.
Well, she's been trying to get a mammogram for a year at age 31.
I've been trying for a year. And also like trying to get the experience of the average young Black woman, someone who like is actually in this space for my age, just so you know what this is like. And I keep on I got that referral from my PCP, and then I keep on going to these websites to make an appointment, and it just knocks me off when I put in my birthday because I'm young. Yeah. And so, but the interesting thing is, I recently tried to find a new PCP because I'm retired. And it's funny that you're going to a new oncologist clinic because this is like an interesting thing because we do tell people to be the CEO of their own health, to be a girl boss. And for me, that says like, yes, date around to find the doctor that you want that works for you. Yeah. So I did a primary care appointment with this doctor. I didn't want to go at first, not because I'm busy, but I've also been telling people keep your appointments. So I would take my advice, go to this appointment. Thought it was in person, ends up being virtual, log in anyways, even though like I'm looking for something in person so I can like actually have someone feel me up and touch my boobs and tell me like I want, please. But no, so I go to this online appointment and she basically, is like not directly dismissing me, but I can feel that she is not understanding the urgency with which I'm giving. And so then she basically said, like, I'll try to help you get a mammogram, which is like where we ended. But the thing for me that was interesting was this. I also went to this appointment because I quickly saw that it'd be $50 to cancel. Right. So I was like, just go, just go. And then I got the bill for this appointment where I felt dismissed, and it was $100. It would have been cheaper for me to have not gone. Now, what's crazy about this is it made me like reflect back on my learnings, or just like my teachings around like I'm telling people to go date for doctors, and I'm now saying like I now know how like that might cost money, and like let me be clear about I'm saying that, but I also want to be honest about like how I don't have a solve for that piece, because it's nice of I get to go try to figure out which doctor works for me. If that was my last $100 though, I would not be in this scenario.
So
Right.
can we use that to go back to your comment on people don't have internet access?
Yeah.
Because I
Yeah.
think
No,
that's
I
a really
think,
important point on access to care, and I actually don't think people understand that. I think in the world of ChatGPT and AI, everyone's like, "Oh, cool, new tech. We can solve healthcare problems with AI." And I'm like, "Well, people don't have internet access, you guys. We're still in the world
yeah,
of
No,
I
and
taught
AI scares me
in an
to
inner city school during COVID, right in DC. My entire school is like 99% black population in Northeast DC, and so that was my first time as somebody who did grow up, really like privileged, and to see how many houses did not when we sent Chromebooks home to these kids to do their online learning at home, and they don't have.
yeah.
And so it was a moment for me to just kind of put it together and kind of clue in, because it was alarming to go ahead and make sure that all of my families not only had the devices, but also the Wi-Fi, even bandwidth
Yes.
to do that, to do their online schooling during COVID.
Yeah. We also find, we did a little research. We did a project on digital health and, telemedicine. And we find even, most Black women have a smartphone. The penetration's like 95% or whatever, right? But that smartphone is the household computer. So during COVID, for example, that was the place where their three kids did the homework with a single mom, right? They all had to share the phone, or they didn't have the bandwidth. They had the phone, but they didn't have the bandwidth to conduct an interview with a doctor, right? Or they didn't want to share their business in a small apartment where everybody could hear them on the phone with the doctor. So they didn't have privacy. So there are a lot of issues around telehealth that we're not ready for.
Yeah.
AI scares the shit out of me. I have to say it. I'm sorry, because if you look at AI is built on the input that people are putting into it. What color are they? What
Yeah.
brains are they? What
Yes.
education level are they?
Mm-hmm.
Who are these people, right? If they're inputting, and so they're building a system that's
Yes.
automatically flawed, right? And to me, it's going to be racism on steroids, because they're going to make decisions. They're not going to have a heart. Like even people who are ultimately racist, somewhere there's some level of emotion that's making them, that's involved in their decision making. This is not going to be that. It's not going to have that, and it scares me to death until we get that right. So I tell everybody, if you can participate in building AI, please do, because it's all going to come back to haunt us. And we now live in this society where we have license to be racist.
Well,
We have a license.
it's still
Yeah.
gonna pull from, like, even though like today there's so many more black articles and so many more people populating the content that
Right.
we take in.
Yeah.
With that said, AI is still going to pull from all of the years where
There
everything
wasn't
wasn't
content.
content, or like
Right. There
content
wasn't content.
that people of
Yeah.
color created
Yeah.
wasn't being like
Yeah.
honored, and so like
Right.
it's still going to skew.
It's going to take a long time for it to get right. I think, you know what I mean?
Yeah.
Because of what's going in. It's like shit in, shit out. Sorry.
No, don't apologize. I think that's right. I think that's right. I think that's absolutely right. I think the amplification of bias, the amplification of racism, the amplification of broadly, generalistically speaking, the darker side of humanity, I think happens. And I think
That's why we can't change that. I know I'm a badass. I can't change racism. I can't. I can't change illicit bias. But what we can do is educate Black women. And that's what we do every day. And we have an HBCU internship program to educate these young women who are pre-med students to say, here, how can you be a better doctor? I know a lot in here, but we educate women and say, here's what you need to know. Here's how you need to be the girl boss of your bodies. Here are the questions you ask your doctor. Here's the kind of care you demand. And here's how you talk to people. And you can't, you have to own this and help yourself. And that's what we teach people.
Ricki, I want you to talk about two things you just mentioned. One was briefly, you mentioned single moms in the Black community. And if I remember the stats, it's staggering as to how many.
73%, 73% single moms.
So can you
It's
talk about
huge.
how does that come to be? And then how does it affect cancer, right? Because it's a very specific lens when you are a single mom going through treatment. I think
Yeah, and it's huge. I mean, we don't have a data point for the percent of single moms that have cancer. We don't have a data point, but we do know that that it's a huge number, and we know that they're the breadwinners for their family, and when they get sick, the household is at risk. Well, frankly, cancer is a disease, is a family disease, no
yes.
matter who is in your family, right? Whether it's your kids, you're married, whatever.
Yep.
But clearly, if you're the breadwinner for your family, you're the holder of the health insurance. So if you stop working, anybody could get sick and die, right?
Yep.
And so it's a huge thing. And we know that Black women under 35 are getting breast cancer at twice the rate of white women and dying at 3 times the rate. So we have right now 2 patients we're talking to. They're 24 with metastatic triple negative breast cancer. We have the manager of our triple negative support group, Deltra. She's 38. She has 5 kids.
5 girls.
5 girls. 5 girls, metastatic triple negative breast cancer. And she's thriving, God bless her. But she got diagnosed at 34. Um, um, and she's the norm. We have Latoya, who's 39, and she got diagnosed at 36. She has 3 babies. There were 3 babies under 7 when she got diagnosed, and she had stage 3B, but her doctor basically deprived her of one of the best drugs we have for triple negative, Keytruda.
Just to be clear, though, she's not a single mom.
Oh, she's not.
Yes,
She's married.
she has a great,
She has a
her
great
husband.
husband.
But I think the thing that, like, you should get back into her story because it goes back to the DMV. But
Yeah.
but I think too, it sucks when you find out the story that like they became a single mom when they got diagnosed.
Yes.
Like that happens a lot
Yeah.
too,
That happens a lot.
and that's what's awful. Because I think about Latoya. I made me think of Latoya's husband and how he's like.
He's a
I
part
wish I
of.
could talk to so many
Yeah.
how to like be a part of their lives and not
Not bounce, but we do have a lot of men that bounce.
because it's a story that like men do.
Or the women leave their husbands because they're not feeling supported. Deltra left her husband
Hmm.
with 5 girls and triple negative breast cancer and metastatic. So yeah, I should have brought Latoya up in a no mom thing, but still, I think that we have to look at the impact on our families and look at the impact on our children and what's happening with them, even with their genetics or their family history, to help teach them. We have Michelle. Michelle is married, has 2 kids, but she's she has a 7-year-old daughter who's like a little badass. She actually interviewed me for her own little interview series for her mom. But she interviewed her mom's doctor. She interviewed me. She has like a whole little YouTube channel of like videos that she's made. But it's a family disease, and we have to rectify that, and we have to help all women, but like the single women are really at risk. And most of them do have, most Black women have a matriarch, whether you're single or whatever, you have a matriarch or Black women that take care of you. But still, we met a woman last summer. She was 38. She had stage 3B triple negative breast cancer. Both her mom and her mom's sister also had triple negative breast cancer within the last 2 years, and they never talked about it. They didn't know that each other had it, the sisters, until the daughter had it and the niece had it. And they finally admitted it to each other. So these are the family situations are insane.
And I think too, like when you mentioned single moms first too, I've been thinking this has been we've been talking about this conversation for a minute. I'm like, I have this her story worksheet. I think it's great. It's pretty comprehensive of like not just breast cancer, but diseases that are risk for breast cancer, so prostate, ovarian, cervical, hypertension, diabetes, colon, all of that. And it says like go through your mom's side and go through your dad's side. So I've always been conflicted with passing out this worksheet because that's not always what families look like anymore. You have so many different family structures. So I think about the LGBTQIA community who like might have not a different relationship with their parents now. I think about people who are adopted. I think about the single mother, single father, anything in that space where you might not have access to your genetic history. And if you have a family that's not talking about health, right, you're really at a disadvantage to knowing your risk. So how do we, it made me think like, if you're adopted, you should get free genetic testing at age 18 or like whenever the age, but like that should be because like you should have access to your family history in some capacity. And so I think it's a twofold issue of like genetics, family history, her story. But like having like knowing both those, but if you don't have access to knowing both those, what do we do?
Yeah. We met a woman last week that is adopted, and and she's really angry about health. She works for NIH. And so she spent a couple of years looking for her birth parents. She found her birth mom about 8 months ago, and her birth mom's family is riddled with breast cancer.
Oh, wow.
All at young ages. And so she immediately went and got herself checked out, but she's angry about the fact that no one could help her with that, and that she had to go find herself. And like, how many women are in her situation where like she has like so much breast cancer on her mother's side, and she knows nothing about her father's side, but still just knowing about that just like made her just, mad. Like, oh my God, like, what do I have to do now? And she's trying to fix herself.
Ricki and Hayley, you and I could talk honestly for hours, I'm almost certain. And we're talking about such complex, such nuanced aspects of Black breast cancer that if you guys are up for it, I'd love to do part 2 and dive a little bit more deeper into some
Yeah, let's do it.
Because I think it's really important to talk about things. I'm not sure the broader breast cancer community hears it often enough. In fact,
we'd love to. There's so many issues and there's so much work to do, and so many, it's always like, okay, what mountain are we going to climb today? What are we going to tackle? And I think that we work really hard to be, I say that we're impatient about being iconic, and we are just in the community. And what Hayley's job is basically to take us where Black women live, work, play, pray, and slay. And we know that we have to meet them where they are and educate them with stuff that they've never heard of, that they might have any idea of, but they need to know. So that's what we do. We'd love to do more.
And it's fun to like have an audience, like to speak to, like you said, the broad cancer community, because I do think like the work we do in clinical trials can translate to.
Oh yeah, can translate.
Like I think this
Sure.
issue that we're seeing in breast is going to be an issue in other places
Yes.
as well, especially with regards to certain ethnicities, races.
Yes.
I want to wrap this episode up with a question for y'all, because one of the things that we've talked about a lot of really, really difficult things today. And not normally, that's not normal, but usually when we talk about these things, most people don't have a level of acceptance that I'm hearing from you. I say acceptance, it may not be the right word, but I just hear this like, this is reality, how do we make it better? And
Yeah.
I would love for you to talk about how you get there, because at least I am not there yet. I am definitely grappling with a lot of like like angsty energy. I'd love for you to talk about that, because I think I actually think it's essential to you guys showing up to be iconic, because you're painting the future. And I find that to be really cool. So I'd love for you to talk about how you got there.
It's unacceptable. The data is just unacceptable. It's just unacceptable. I can't think of a better word. Her sister, she's an older sister, 7 years older. She has 3 babies. So I work for them. My 2 daughters and my 3 grandbabies. They're 3, 4, and 6. I don't want them to ever speak the words breast cancer. And I got about 10 years before they get boobs. So they're my purpose. I think about them all day. So my older daughter, her sister, just had a prophylactic mastectomy a month ago, 2 months ago, because we have a family history and no one can explain this to me. So let's cut the boobs off. Is the only way to get rid of it. But I don't know. I can't go to sleep at night knowing that there's an opportunity to change something. And I know we all do this work. We all can pat ourselves on the back and say we helped somebody today. We sent them to, we hugged them, we took them to chemo, we fed them food, whatever. But until we change the science with conviction, with intention, until we change how we talk about it and think about it with cultural agility, it's not going to change. And the stuff that's been done in the past did not work. Show me where it worked. Why are all these people working on cancer still? Why isn't that fixed? We got a COVID vaccine. We fixed AIDS. Why isn't it fixed? And so I can't rest until it's fixed for my girls.
I think it's just about like being solution oriented, you know what I mean? Which I think can come from a lot of different emotions, right? It could be acceptance, it could be anger, it could be whatever, right? And so whatever's driving you, continue to feel that and use it to be solution oriented. Because I don't think it's a matter of like there's one way to feel. It's more just like what are you doing with it, with whatever feeling you're having to create change, to drive this mission, and keeping in the back of your mind that like cancer is our enemy, nothing else. Like the person that I met that was annoying, the the travel that I have to do, or the things like that. It's just like keeping in the back of my mind that cancer is, and check each other on that, because sometimes you do get busy. The first one to check and be like, clear the make sure it's cancer is an enemy. Focus on that, because and it's when you see people kind of lose sight of that you see people forgetting about the need, the, or just using those guidelines that we know don't work. Right. That's what I feel like that happens, is when we just forget about the mission at hand, and that's like a life being saved.
On that note, you guys, I am so humble that you took the time to do this. Truly, I'm walking away with a very different lens on Black breast cancer. And I am hopeful that people listening in will also have that shift, which I think is absolutely essential to telling a new story in the future. So thank you.
Thanks for having us. We'll come back whenever.
Done.
Take care.
Schedule
Take
it.
care of yourself, my blessee. You're my blessee. You're our blessee.
Thank you. I feel good.
We'll send you a t-shirt.
Yeah, we'll send you a blessee t-shirt.
Anytime. Thank you guys.
Take care. Take care.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.